Hello everyone. Today in this video we are going to discuss about cardiomyopathy in children. As we know, cardiomyopathy is the leading cause of cardiac failure in children with normal heart structure. So we have to know basic about the cardiomyopathy. So in this lecture we are going to discuss about the definition of cardiomyopathy, what are the different types of cardiomyopathy, what is the basic pathophysiology of different types of cardiomyopathy, how to diagnose cardiomyopathy, and what are the treatment of different types of cardiomyopathy. So let's start with the definition of cardiomyopathy. As we know, in the name said cardiomyopathy, that means there is a problem in the cardiac muscles. So it is a primary problem of the cardiac muscle, and it is defined as it is a structural and functional abnormality of the cardiac muscle, that means myocardium, not secondary due to any congenital valvular or hypertensive or cardiac coronary heart disease. That means it is a structural or functional problem of the cardiac muscles, primarily of the cardiac muscles, not secondary due to any other cause. That means it is a congenital problem in which the cardiac muscles is unable to pump or unable to do its normal work, normal function, and that's lead to heart failure. So as we know, the cardiac muscle is doing contraction and also dilatation, and during contraction the blood is coming out from the body, goes into the lung, and after purification of from the lung it is oxygenated and then is reverse back to left atrium, and then from the left atrium to the aorta due to the contraction of the cardiac muscle. When there is a problem in the cardiac muscle, the cardiac muscle is unable to pump the blood from their chambers to the respective parts. So that's why there is a signs of heart failure. So this is the main pathology and the main definition of cardiomyopathy. That means it is a primary problem of the cardiac muscles, that means myocardium, not due to any secondary cause of muscle problem. So what are the different types of cardiomyopathy? According to the based on the anatomical and functional pathophysiology, cardiomyopathy is divided into 5 types. Come to the first type of cardiomyopathy. So dilated cardiomyopathy is the most common cause of cardiomyopathy in children, and the most common cause of dilated cardiomyopathy is idiopathic. So, and the second most common cause of dilated cardiomyopathy is viral myocarditis, and after that, the third most common cause of cardiomyopathy is any inherited disorders. That means any inherited familial disorders can cause dilated cardiomyopathy. So the most common cause of cardiomyopathy is idiopathic. Second most common cause of cardiomyopathy is viral myocarditis, and after that there is an inheritance problem of the cardiac muscles. So there is different syndromes is associated with dilated cardiomyopathy. First, start with a syndromes of which is associated with dilated cardiomyopathy. So if we found any patient having congenitally dilated cardiomyopathy, we should think about some congenital problems, congenital syndromes in or some syndromes which causing dilated cardiomyopathy. So first syndrome which is most commonly associated with cardiomyopathy is Duchenne muscular dystrophy. That means any muscular dystrophy. Any muscular dystrophy is associated with dilated cardiomyopathy except two muscular dystrophy. One is first is the myotonic dystonia is not associated with dilated cardiomyopathy. It is mostly associated with hypertrophic cardiomyopathy. And second is the Friedreich's ataxia, which is mostly associated with hypertrophic cardiomyopathy. It is very much important. That means all muscular dystrophy is associated with dilated cardiomyopathy except myotonic dystonia and Friedreich's ataxia. After that, carnitine deficiency is also associated with dilated cardiomyopathy. Barth syndrome is also associated with dilated cardiomyopathy. In Barth syndrome, what are the features? In Barth syndrome, we have found that it is an X-linked recessive disorder in which we found dilated cardiomyopathy along with problem in the mitochondria and also cyclic neutropenia. So it is very much important to know about Barth syndrome. So in Barth syndrome, there is cyclic neutropenia, dilated cardiomyopathy, and also an abnormal mitochondria. Next is Carnes-Shire syndrome. That is Carnes Shire syndrome. In Carstner syndrome, we found progressive ptosis, and also there is a external ophthalmoplegia along with this retinal abnormal pigmentation along with dilated cardiomyopathy. So these are the congenital syndromes is mainly associated with cardiomyopathy. First is the any type of muscular dystrophy, and also there is any storage disorders or any other mucopolysaccharidosis, glycogen storage disorders, or there may be a hyperthyroidism that may associated with dilated cardiomyopathy. Now, what is the basic pathophysiology of dilated cardiomyopathy? That means what happened in dilated cardiomyopathy. As in this picture, we are seeing that during normal systole, the cardiac muscles, the blood which is come out from the body to the right atrium. This is the right, this is left, and this right atrium it is go to right ventricle and then to the lung, and from there it is come to ventricle, left atrium, then left ventricle. During systole, there is a contraction of the right and left ventricles, and due to the contraction the blood goes to the aorta from the left ventricle and pulmonary artery from the right ventricle. And diastole, in normal heart there is a dilatation of the both the ventricles. As we in dilated cardiomyopathy, as I say, it is mainly the pathology in the left ventricles. So left ventricle is getting dilated, and due to the dilatation of the left ventricle, the blood which is come out from the left atrium enter to the left ventricle. During systole, the heart muscle getting dilated and is unable to pump enough blood to the aorta. So that's why there is a fluid filled or blood filled in the left ventricle, which is then regurgitated to the left atrium, and after that it goes to the lung, and from the lung it regurgitated to the right ventricles and then to the right atrium, and then goes to the back to the body. So during diastole, there is a huge dilatation of the left ventricle also, and there is a blood stasis. So what is the features of dilated cardiomyopathy? As I said, there is a dilatation of the left ventricle. So left ventricle getting dilated, and the blood is not pumped out from the body, from the heart to the body. So that means there is a afterload failure. Afterload failure. As there is afterload failure, and there is a backflow to the lung, and the blood which is coming out from the body, it cannot enter to the lung because there is a pressure increase in the lung, and that's why that means there is a right heart also failure. That means preload failure. So that is systolic and diastolic failure. That means preload failure is the main, and afterload failure is the main pathophysiology of dilated cardiomyopathy. So what are the features of preload and afterload failure? As I say in my heart failure chapter or discussion, I say that preload failure is the signs of preload failure are raised ABP, tender hepatomegaly, and edema, pedal edema. And the afterload failure, the signs are, that means the left heart failure is the poor pulse volume, and also there is a basal crepitation. So these are the features of dilated cardiomyopathy. So the treatment of dilated, first is the diagnosis of dilated cardiomyopathy. In ECG, we found that there is a cardiomegaly as the left ventricle getting dilated. So in X-ray, we found that the cardiomegaly. In ECG, we found there is a left ventricular dilatation. And echocardiography is the investigation of choice. Now, next, the treatment of dilated cardiomyopathy. So, first treatment of dilated cardiomyopathy is to decrease the preload failure. That means the preload failure. So, in my heart failure chapter, as I say, the treatment of preload failure is the diuretics. So, start with the diuretics, and after to treat the preload failure, we give ACE inhibitor as it is a arterial dilator. So, diuretics and ACE inhibitor, it is the both are the drug of choice, and we give aspirin as there is a stasis of the blood in the heart may cause thrombosis. So these three are the first line of treatment. After this, for these three drug, if the symptom persist, then we can give add digoxin, as the digoxin having increased cardiac contractility power, so it may be increase the cardiac contractility to decrease the afterload failure. So we can add digoxin, and we can add also carvedilol. The what happened in carvedilol is it decreases the cardiac remodeling, also it increases the cardiac contractility power. So these are the treatment of dilated cardiomyopathy. So dilated cardiomyopathy is very much important as it is the most common type of cardiomyopathy, and it is the most common cause of heart failure due to the in normal heart, structural heart. So direct cardiomyopathy is very much important. So in direct cardiomyopathy, there is a preload and afterload failure. That means systolic and diastolic failure. And the investigation of choice is echocardiography. Next is hypertrophic cardiomyopathy. It is the second most common type of cardiomyopathy, and it is mostly due to it is inherited, and the most common inheritance is autosomal dominant. So hypertrophic cardiomyopathy is mostly the second most common type of cardiomyopathy, and it is mostly due to inherited, and it is autosomal dominant in type. In hypertrophic cardiomyopathy, what is the basic pathophysiology? And there is in hypertrophic cardiomyopathy, that means there is a hypertrophy of the cardiac muscle. There is a hypertrophy mainly in the left ventricles getting hypertrophied. It is only the left ventricle or the septum getting hypertrophied. As there is a hypertrophy of the cardiac muscle, that means mainly the left ventricle. So there is no systolic problem. That means the systolic problem is not there. The dysfunction is that during the diastole, as there is a more muscles in the heart, so there during diastole the heart is not getting enough space to drain the blood from the left atrium. So there is a small amount of blood enter to the left ventricles, and this small amount of blood enter to the body, and that this small amount of blood from the left ventricle, it cannot cope up with the normal demand. So that is the problem in the hypertrophic cardiomyopathy. That means there is a failure in the diastolic failure. It is not in the systolic failure or not in the cardiac contractility. In hypertrophic cardiomyopathy, the contractility power is also much more increased. That means the cardiac contractility is increased, the systolic function is also increased, but there is a diastolic failure. And there is a different types of hypertrophic cardiomyopathy is there. Firstly, when there is a hypertrophy of the heart muscles, as there is a hypertrophy of the heart muscles, this hypertrophy of the heart muscle may not or may not cause any problem to the cardiac chamber space. If there is a cardiac chamber space is normal, then there is a no problem in the systolic or the diastolic function. So this one type of hypertrophic cardiomyopathy, there is a muscle is getting hypertrophied, but there is a no problem in the systole and diastole. That is called asymptomatic hypertrophic cardiomyopathy. Next type of hypertrophic cardiomyopathy is when there is a more dilatation of the septum, and this septal dilatation causing problem in the this septum dilatation causing problem in the aortic small narrowing the aortic root, and this causing the problem during the systole. During systole, the blood cannot goes to the aorta because there is a narrowing in the passage of the aortic root, as there is a septal hypertrophy. This type of cardiomyopathy is called idiopathic hypertrophic subaortic stenosis. That means due to the septal dilatation, there is a septal dilatation. There is a small narrow in the subaortic space, and there is a problem in the systolic functions, and the blood cannot goes out from the aorta. And third is the when there is a dilatation of the heart muscles, which causing obstruction of the narrow obstruction of the aorta, and there is a blood cannot goes out from the aorta, and this is called obstructive hypertrophic cardiomyopathy. That means there is a complete obstruction. So in hypertrophic cardiomyopathy, we found there is a diastolic problem, mainly the diastolic problem. Only when there is a systolic problem is there, this is the definite indication of heart transplantation. This is an MCQ. When there is a systolic function is having problem in the systolic function, that is the indication for cardiac transplantation. So in hypertrophic cardiomyopathy, there is a three types of hypertrophic cardiomyopathy. One is asymptomatic, when there is a small problem of the diastolic function, but the systolic function is normal. But in hypertrophic obstructive cardiomyopathy, there is a problem in the systolic function also. That means the blood cannot come out from the during the systole. So this time we need to treat the heart, and we have to transplant the heart. Now, what are the symptoms of this hypertrophic cardiomyopathy, as there is a decreased amount of blood enter into the heart during the diastole, as the heart muscle is getting enough hypertrophy. That means the heart chamber is small in quantity, the heart and there is small blood into the heart chamber of the left ventricle. Small amount of blood and goes to the aorta, from the aorta to the body. That means there is a poor pulse volume, there may be a syncopal attack, there may be a chance of cardiac ischemia, or there may be a chance of hypotension. So these are the features of hypertrophic cardiomyopathy. So it is the most common cause of, it is a most common cause of sudden cardiac death in sports or athletes, as because there is a small amount of blood come out from the aorta. So there may be a signs of small chest pain. Sometimes there is maybe a anginal pain, or there is maybe a syncopal attack, or there may be a chance of any sudden cardiac death. So in ECG, it is shown that there is a left ventricular hypertrophy, as there is a muscle mass more in the left side. So there is a left ventricular hypertrophy, and there is a abnormality of the deep, abnormally seen deep Q wave, and also absent R wave in the left precordial lead. That means V4 to V6, in which we found. So in this picture, we found there is a deep Q wave, but there is a no R wave. There is a deep Q wave but no R wave. So this is the pathophysiology of septal hypertrophy. So an echocardiography is the investigation of choice. Now the treatment. The treatment is the beta blocker. The beta blocker is the first line of drug of choice. Why beta blocker is first line of drug of choice? As because beta blocker decreases the cardiac muscle, there is a relaxation of the cardiac muscles, so that may be a increase amount of the diastolic time also, and also increases the heart compliance. So beta blocker is the first line of treatment. Along with this, we can add CCB, that means calcium channel blocker. So in small children, we start with propranolol, that means beta blocker with propranolol, and after that, if the in elder children, we can give atenolol and verapamil. If the beta blocker is not having in beta blocker, and verapamil with atenolol when there is a no improvement after giving only a single dose of beta blocker. After that, if there is features of heart failure or features of sudden cardiac death, then Moro's myomectomy is the treatment of choice. And if there is a chance of heart failure, or if there is a features of heart failure, as because there is a small amount of blood enter into the heart, there is a backflow, and there is a features of heart failure. So in heart, if there is a features of heart failure, we can judiciously give digoxin. We can judiciously give diuretics, and diuretics decreases the preload failure, but we cannot give digoxin, as because digoxin is contraindicated. Why? If we give digoxin to this child, it will increases the myocardial contractility, and which lead to ischemia or sudden cardiac death. So digoxin is contraindicated in hypertrophic cardiomyopathy. We can add AC inhibitor to some extent if there is a features of congestion. Now, if we found any patient having hypertrophic cardiomyopathy, so we have to do some basic investigation for their first generation brothers or first generation siblings. So as I say, it is most commonly it is inherited. So we have to look for look for the sibling having this type of asymptomatic hypertrophic cardiomyopathy present or not. So we for them we do ECG, basic ECG, and chest X-ray and echocardiography. So basic ECG we have to do in siblings. If we a patient having hypertrophic cardiomyopathy, it is the basic investigation. And if there is a features of left ventricular hypertrophy in ECG, then we can go for echocardiography. Now, the third most common cause of cardiomyopathy is restrictive cardiomyopathy. This is very rare in children, and the most common cause of restrictive cardiomyopathy is idiopathic, and we can found some systemic infiltrative disorder in which we can found the restrictive cardiomyopathy. That means if the patient having SLE, scleroderma, sarcoidosis, amyloidosis, or mucopolysaccharidosis, we can find restrictive cardiomyopathy. forgot to tell that in Pompe's disease we found hypertrophic cardiomyopathy, and other form of glycogen storage disease we found dilated cardiomyopathy. So in restrictive cardiomyopathy, in mucopolysaccharidosis we can found restrictive cardiomyopathy. What happened in restrictive cardiomyopathy? So this is the heart muscles. In restrictive cardiomyopathy, the heart muscle did not increases its size. That means there is a restriction of the heart muscle movement. So in this problem, this is mainly problem in the left ventricles. So left ventricle cannot getting dilated as there is a restriction of the movement. So there is a systolic function is normal as the heart muscle contractile function is normal, but it is not dilated. The heart muscle is getting not enough dilatation during the diastole. So there is a diastolic problem. So it is a problem in the diastolic failure. That is a failure of the, it is diastolic failure, and in which we found that heart muscle cannot contract, cannot dilate, as because this there is a backflow of the blood and it is enter into the right ventricle, and problem is congestion. So treatment of choice is diuretics. That means preload failure. So diuretics is the drug of choice. AC inhibitor is contraindicated. It is only decreases the afterload, but it is not increases the cardiac muscle contractility power. So AC inhibitor is contraindicated. Diuretic is the drug of choice as there is a features of congestion. If there is a no congestion, so we do not treat anything. Restrictive cardiomyopathy, first is the treatment of choice is diuretics if there is a features of preload failure. AC inhibitor reduces the systemic blood pressure but without increasing the cardiac output. So it is not indicated. It is contraindicated mainly in a in restrictive cardiomyopathy. We can give CCB because it increases the diastolic compliances. So diuretics is the drug of choice and AC inhibitor is contraindicated. Now last two types of cardiomyopathies. First is the arrhythmogenic cardiomyopathy. It is very rare. It is mainly pathology in the right ventricle. The right ventricle is mainly the muscles of the right ventricle is mainly replaced by fibrous or adipose tissue, and for this the right ventricle getting dilated and there is a fragile right ventricle, and for this there is a systolic and diastolic failure of the right ventricles, and we found that there is a congestion. And in ECG we found that there is a tall P wave in lead to an inverted T wave in V1 to V4, and the symptoms are syncopal attack or there may be signs of preload failure. That means there is a signs of congestion, and the treatment of choice is diuretics. And left ventricular non-compaction cardiomyopathy, that means the left ventricle getting dilated as there is a hypertrabeculate formation of the left ventricular apex or lateral wall. That means left ventricle getting dilated, and it is mainly present in infancy. It is mainly present in infancy or intrauterine life. There is a features of left heart failure, and there is a problem in the systolic function, and cardiac MRI is the investigation of choice. So these are the different 5 types of cardiomyopathy.